Good afternoon, everyone. We welcome you to yet another session of Cuddles online Neonatology webinar series. And in this presentation, we are going to discuss some recent updates in the management of respiratory distress syndrome. I'm Dr. Aparna from Kim's Cuddles Kondapur Neonatology team. So the basic premise of management of RDS has been to prevent lung injury, understanding the concept that prevention or lung protection is better than treatment or better than cure. So there are some things that we have already learned or understood about the management of respiratory distress syndrome, and we have discussed this over multiple sessions in our own webinar series as well. We know that management of respiratory distress syndrome or holistic evaluation and management of prematurity starts from the antenatal period. So good antenatal practices include administration of a complete course of antenatal steroids and antenatal magnesium sulfate for neuroprotection, trying to transfer the preterm baby in utero as far as possible to a tertiary care center or a quaternary care center where the baby can be managed right from the word go or from the golden minute, and appropriate identification and management of chorioamnionitis or pre-labor rupture of membranes, preterm rupture of membranes. Intrapartum management of RDS includes, again, some very broad, important categories, including the thermal bundle or temperature bundle, which includes a bundle of interventions to optimize the admission temperature of preterm newborns, including the use of polythene wrap, the use of exothermic mattresses, stockinette caps, heated humidified gases for the posture pressure ventilation or delivery room CPAP, measuring the admission temperature, using transport incubators for transporting preterm babies from the labor room or OT into the NICU, and keeping the room temperature more than 25 degrees Celsius. Along with this, gentle cord care in the form of delayed cord clamping by more than 60 seconds, use of blended air oxygen mixture to titrate the fractional inspired oxygen concentration to target pre-rectal saturations as per the minute-specific saturation targets, the use of early CPAP or delivery room CPAP wherever required, and administration of early rescue surfactant administration, gentle posture pressure ventilation using the TP's resuscitator over a self-inflating bag. These have been some useful strategies that have been found to improve the outcomes of preterm babies in the delivery room. Further on in the NICU, the first few hours or first few days of postnatal respiratory management also plays an important role in the lung protection. So some useful strategies include the use of early CPAP for babies with the mildest of signs of respiratory distress. In newborn babies deemed to have high risk of CPAP failure, such as babies born less than 28 weeks or babies who had asphyxia at the time of birth may benefit from non-invasive ventilation over CPAP. However, if the baby does need ventilation, we know that the baby needs to be provided gentle ventilation. Gentle ventilation is a term that is used to denote the use of optimal PEEP, the least possible PIP, in order to drive the optimal tidal volumes, which are to be kept at something like 4 to 6 ml per kg, and using least possible I times and the least FiO2 required to target saturations between 91 to 95%. Use of relatively high respiratory rate, which is kind of in sync with the baby's inherent natural respiratory rate, is permitted. Targeting oxygen saturations between 91 to 95% has been found to translate into lesser mortality, although it is associated with a slightly higher incidence of retinopathy of prematurity. However, this is still manageable with the advent of laser as well as anti-VEGF therapy. So this is from the NeoProm systematic review, prospective meta-analysis, individual patient meta-analysis from the NeoProm studies. The other useful strategies postnatally that are already known to work include the use of less invasive surfactant therapy, which is coming up in a big way, sepsis prevention, as well as appropriate aggressive nutrition, both enteral as well as parenteral. So we'll try and discuss some recent advances in these 5 domains today. We'll begin with the delivery room management of RDS, and here we shall be discussing about the role of sustained inflations, gentle posture pressure ventilation, and blended air oxygen a little bit more in detail. We'll then discuss about the newer advent of lung ultrasound in identification of RDS. We have had just last week a lecture by Dr. Vamshi Krishna on this. Thirdly, we'll discuss a little bit about what our recent understanding is on the choice of surfactant replacement therapy, the mode of its distribution, including LISA and MIST, and some newer modes like nebulized surfactant and the use of laryngeal mask airway. And lastly, some newer advances in non-invasive ventilation. So delivery room management of preterm babies in appropriate early management of respiratory distress, what we already know is our delivery rooms must be equipped with both oxygen and air ports so that they can be connected to a blender, and a blender should be used to titrate the fractional inspired oxygen concentration that is being delivered to between 21 to 30% for optimizing the baby's saturation right from the birth. And using blended air oxygen concentration has been definitely found to improve the compliance to saturations remaining within the target range, avoiding both hyperoxia and hypoxia. Now, coming to the resuscitation devices or the PPV devices, positive pressure ventilation devices, a TP's resuscitator is found to be associated with some advantages, including the controlled and sustained delivery of peak inflation pressures, the ability to deliver PEEP or positive end expiratory pressure, the incidence of lesser operative fatigue that is associated with the TPs, and its feasibility as a transport device that can be used for brief provision of ventilation or CPAP while the baby is being transported. However, this critically requires an ongoing gas source, like a self-inflating bag, which may work without even a gas source. The TPs can be used for providing both positive pressure ventilation as well as delivery room CPAP. Now, early CPAP, as we discussed earlier, is associated with a small but clinically significant reduction in the incidence of bronchopulmonary dysplasia at 36 weeks, with a relative risk reduction of 11%. Although this is statistically significant, this is a modest reduction in the incidence of BPD. However, more exciting immediate benefits of early CPAP are the significant reduction in the need for intubation and ventilation, and significant reduction in the need for surfactant replacement. So this is a chart showing the time that is taken for reaching the target saturation level of more than 90%, which usually is around 10 minutes in most babies, both term and preterm. So the dictum is in babies who are born less than 35 weeks, one starts with a blended air oxygen mix with an FiO2 of 21 to 30%, targeting preductal SpO2 to remain within the target minute-specific target range as shown in this table. So this saturation target table is not different between term and preterm babies. So it starts from 60 to 65% at 1 minute, and it reaches 85 to 95% by 10 minutes of life. So you can see that the probe is to be applied to the baby's right upper limb or preductal limb. So what is new here in the delivery room or intrapartum management of respiratory distress syndrome? So what is really new here is researchers tried to test an intervention called as sustained inflations. So sustained inflations were breaths that were delivered using relatively high peak pressures, which were up to 25, 30, or sometimes even 35 centimeters of water, and delivered for a long inflation time. So the I time used to be kept at 10, 15, or 20 seconds. And this strategy, when initially tested in animal or rodent lung models, was found to translate into increased functional residual capacity and hence lesser requirement for mechanical ventilation, intubation, and need for surfactant, and was thought to potentially result from better recruitment of the lung at FRC. However, a large study, the SAIL study, sustained inflations, aerations in lung inflation study, failed to show any significant clinical benefit of sustained inflations, and rather showed a significant increase in mortality in the group of preterm infants who received sustained inflations at 7.4% mortality versus 1.4% mortality in the standard resuscitation arm. So neither was sustained inflation associated with any clinical benefit, and rather it was thought to or possibly found to result in significantly higher mortality, probably because of higher risk of lung injury, air leak syndromes, pneumothorax, and subsequent lung issues leading to higher risk of death. And hence, this strategy has now been dropped completely or given up completely. The other new advent in resuscitation in preterm infants at risk of RDS is with regards to the use of initial FiO2 during resuscitation. So although the current ILCOR guidelines continues to recommend initial FiO2 concentration of 21 to 30% in infants born less than 35 weeks, a recently published meta-analysis in this year, in 2024, which included 1,055 infants from 12 studies randomized to receive high versus low FiO2 concentration, found that use of high FiO2 concentration was associated with lower mortality among infants less than 32 weeks. So this came up quite surprisingly and was quite contrary to our notion that one should try to limit FiO2 initially to less than 30%. So in this meta-analysis, the use of higher concentration of FiO2 defined as more than equal to 90% was associated with a nearly 55% reduction in mortality, and which was statistically significant when compared to lower initial FiO2 concentration less than equal to 0.3 or 30%. However, for the moment, this evidence still needs to be taken with a pinch of salt, because the confidence intervals of the relative risk are quite wide, which means that studies which are done now subsequently may potentially alter these findings, and that needs to be seen in the coming years. And direct comparison between these two FiO2 limits was only from 8 randomized controlled trials, which included 650 babies. And prediction intervals change the interpretation. So this is a newer area that is coming up, and more on this may be understood in the coming years. So we have discussed the delivery room management, where two new findings where there is no role for sustained inflations, and there is potentially some benefit with higher FiO2 concentration used for positive pressure ventilation in preterm infants. Now, the next aspect is about the baby being identified, or how do we make the diagnosis of respiratory distress syndrome requiring surfactant. So traditionally, after the baby comes to NICU, when there is clinical evidence of respiratory distress syndrome, we all would start CPAP. Most of us use bubble CPAP, which is convenient and not very, it's more cost effective. Now, as per the European Consensus Guidelines 2019, babies with RDS should be given rescue surfactant early in the course of the disease if they are having worsening with FiO2 more than 30% on CPAP with at least 6 centimeters of water pressure. So this is very similar to what has been recommended by the NNF Clinical Practice Guidelines. So none of these existing guidelines mandate the requirement for a radiological investigation like the chest X-ray evidence of respiratory distress syndrome. Now, more and more in recent times, the advent of point-of-care lung ultrasound, which is performed using relatively high-frequency linear probe between, say, 8 to 12 megahertz frequency to identify changes suggestive of RDS is becoming more popular. So some typical changes that can be identified in the lung ultrasound include the following. The presence of lung consolidation and air bronchograms are most characteristic. So the left-hand side picture shows both consolidated lung in the left lower portion and the presence of air bronchograms, which are because of the terminal bronchioles that are filled with air standing out against an opaque background. And we may see something called as alveolar interstitial syndrome, which we'll be discussing in the next slide in a little bit more detail. The presence of bilateral white-out lung, as you can see on the right side. The presence of a thickened pleural line may also be seen. Now, in contrast, the presence of A lines are usually associated with a normal healthy lung, and A lines which run parallel to the pleura typically would disappear in a RDS lung. So this was alveolar interstitial syndrome on the right-hand side, which is characterized by 2 or more sequential confluent B lines. So if you see All these changes, a thickening of the pleural line, the presence of diffuse B lines, alveolar interstitial syndrome, the presence of subpleural consolidation, and air bronchograms, all these are signs that are suggestive of RTS. So researchers, investigators have tried to define or try to come out with some scoring systems wherein you can score the lung ultrasound findings based on these different variables in the various portions of the lung divided as upper anterior, lower anterior, lateral lung in the right side as well as on the left side. So the presence of each of these findings gets a corresponding score. So for example, if you see at least 3 B lines, then you would give a score of 1. Likewise, if you see crowded or coalescent B lines with or without consolidation, limited to the subpleural space, it gets a score of 2. So it has been seen that infants with an elevated lung ultrasound score, usually a score of more than 5 to 6, were at significantly higher risk of surfactant requirement or treatment when compared to infants with a lung ultrasound score of below 5 to 6. So infants with a higher score are at 7.5 times higher risk of developing surfactant deficiency and requiring surfactant when compared to infants with a normal or a lower score. And diagnostic utility, as measured by both sensitivity and specificity, have been found to be reasonably good for the diagnosis of neonatal respiratory distress syndrome. So this is another new advent which may be coming up more and more in the coming days. The advantages of lung ultrasound are that it avoids radiation exposure, and it is something that can be performed readily with minimal turnaround time. However, it requires training, experience, and it might be subjective, and these are some relative disadvantages. The third area where there is a lot of research happening is the choice of surfactant. So we have broadly 2 types of surfactant available. One is the natural surfactant replacement, the different types of natural surfactant, and the second one would be the synthetic surfactants. Again, in natural surfactant, we have minced lung extracts, wherein animal lung is minced and the non-phospholipid components are actually extracted, and they may be destroyed and they may be removed from the extract. Examples of lung minced extract surfactants include the Surfactant, which is bovine origin, called as Surfactant, Curosurf, which is porcine in origin, also called as Surfactant alpha. The other type of natural surfactant or animal-derived surfactant would be lung lavage surfactant, which is produced in a slightly different manner, wherein the baby's lung is given a lavage using saline solution, and surfactant is extracted from the effluent. So different types of lung lavage extracts include bovine lung extract surfactant or BLESS, which is also called as Neosurf, and Intrasurf, Albiofact, etc. So most of the natural surfactants may provide some degree of surfactant protein B and C, but they may have relatively less concentration or almost nil concentration of the other surfactant proteins. Although the older generation synthetic surfactants, which were earlier available, had 0 surfactant protein availability and were also associated with a high risk of pulmonary hemorrhage, this has been done away with the newer generation synthetic surfactants, which have recombinant surfactant proteins that are added to them. So the 2 important surfactant proteins are surfactant protein B and C, which are necessary for the uniform dispersion of the surfactant molecule and for its efficacy. So the newer synthetic protein analogs include lucinactant, which contains recombinant surfactant protein B, also called as synapultide, and the recombinant surfactant protein C, which is venticute or lucipultide. There are third generation synthetic surfactants that try to incorporate both surfactant proteins B and C. So this table gives us the names of various surfactant brands, both the natural as well as the lung extract as well as the lung lavage surfactants and their phospholipid concentration. Please note that the highest concentration of phospholipid is found in Surfactant alpha or Curosurf at 80 milligrams per ml. And this needs to be administered at 2.5 ml per kg in order to provide 200 milligram per kg of phospholipid. So none of the lung minced as well as lung lavage extract surfactants contain surfactant protein A and D. So the older generation, the protein-free, that is synthetic surfactants that didn't have surfactant proteins at all when compared with animal surfactants, it was shown that the animal-derived surfactants or natural surfactants are clearly better because there was significant reduction in the risk of pneumothorax and marginal decrease in mortality. However, with the newer generation protein containing synthetic surfactants, there is not much difference in the efficacy, and both animal-derived and the protein-containing synthetic surfactants are found to be both equally efficacious. Furthermore, among the natural surfactants, if you have to really make a comparison, this is from the NNF clinical practice guideline that looked at the comparison of porcine versus bovine surfactant. So meta-analysis from all the RCTs that looked at comparison between these two types of surfactant did show that there was significant difference. There was significantly lower mortality, lower risk of bronchopulmonary dysplasia, as well as the lower combined outcome of these two morbidities, death and BPD, when one used porcine surfactant when compared to bovine surfactant. So all these reductions were statistically significant reductions. So there was for example, 30% reduction in mortality, 31% reduction in BPD, and nearly 27% reduction in the combined outcome of these two morbidities. When it came to the other clinical outcomes, again, porcine surfactant scored better than bovine surfactant, with a nearly 70% reduction in the requirement for additional surfactant doses. So if you gave porcine surfactant, you may not need a second dose to be given. Likewise, there was also reduction in the risk of air leaks and the incidence of hemodynamically significant PD. So among natural surfactants, it seems like porcine surfactant was possibly associated with better clinical outcomes. But again, when the same dose of porcine and bovine surfactant, that is 100 milligrams per kg phospholipid of either were compared, none of these differences still remain statistically significant. So essentially, it meant that all these differences were predominantly because of the higher dose of phospholipid that we were giving and not because of the surfactant preparation per se. The newer generation protein-containing synthetic surfactants like leucinactant and surfactant, venticute, etc., were found to be equally efficacious when compared to the animal-derived natural surfactants with no difference in mortality or bronchopulmonary dysplasia. So to summarize, as recommended by the European consensus guidelines, natural surfactant, especially poractant alpha at a dose of 200 milligram per kg, seems to be better than 100 milligram per kg of either poractant itself or beractant. And the AAP as well as WHO recommend that we choose from either an animal-derived surfactant or a newer generation protein-containing synthetic surfactant. So this is regarding the choice of surfactant. The fourth aspect where we are going to discuss recent advances would be on the mode of delivery of surfactant. Traditionally, we have been using INSURE technique, which is intubate, surfactant, and extubate. And more recently, we have read or either used or seen the newer modalities like LISA, which is less invasive surfactant administration. MIST is minimally invasive surfactant therapy. LMA is the use of laryngeal mask airways for surfactant administration, as well as nebulized surfactant therapy. Now, LISA combines the benefit of giving surfactant in a spontaneously breathing infant. It allows continuation of CPAP by not breaking the natural seal from the glottis, which ensures generation of PEEP. It also maintains laryngeal function and has the potential to improve patient comfort by avoiding mechanical ventilation. So when you look at the real-time picture of an infant who is intubated, even with a smaller size endotracheal tube, it may snugly fit and cover the entire glottis. And this interferes with the closure of the glottis, which conserves the natural PEEP. This may be further associated with trauma due to mucosal injury while trying to pass a relatively bulky endotracheal tube. However, when we do less invasive surfactant administration using either a thin vascular catheter or an angiocath, usually a 12 French angiocath, or more recently, by using a feeding tube of either 6 French or 8 French caliber. Some of the advantages that have been found are a significantly lesser incidence of BPD, need for ventilation, lesser mortality, severe grades of IVH, as well as bronchopulmonary dysplasia. So again, the NNF India's CPG guidelines published in 2021 compared LISA versus Ensure in preterm infants and found that lesser invasive surfactant administration techniques were associated with 28% reduction in BPD, 25% reduction in the combined outcome of death or BPD, as well as 25% reduction absolutely in the risk of mortality. The other significant advantages were lesser need for intubation and ventilation in the next 72 hours and incidence of pneumothorax. There are different named techniques now that are classified under less invasive surfactant administration, including the use of a flexible suction catheter or a nasogastric tube, semi-rigid vascular catheter. So semi-rigid vascular catheter is what is commonly known as the Hobart technique or minimally invasive surfactant administration. And later we learned a lot of other new names like the Cologne method, which uses a flexible suction catheter, the take care technique that used a nasogastric tube and without a Magel's forceps. And a little earlier, the Sonshore technique used same flexible NG tube, but it used a laryngoscope as well as a Magel forceps. So most of the international guidelines say strongly that either LISA or MIST is preferable. Some come up with a weak recommendation favoring either less invasive or minimally invasive surfactant therapies. But what is most important is one has to standardize the protocol before routinely implementing LISA or MIST. This includes stabilizing the preterm infants after admission to the NICU. Optimization of non-invasive ventilation support. So this includes optimal fixation of the interfaces, optimal humidification, setting the right pressure, setting the right temperature in CPAP circuit, and making sure that we use the right interface. Also important is to decide the right threshold and timing for surfactant administration by LISA, making sure the co-interventions like caffeine are rightly introduced or administered. Earmark the eligibility or inclusion as well as exclusion criteria for LISA. Use of pre-medications is optional, and there is a lot of controversy whether or not to routinely use sedation with LISA. Non-pharmacological interventions like swaddling, facilitated tuck to reduce pain, delineate the exact steps that are to be followed. For example, you would start by introducing a laryngoscope, identify the glottis, and then you may pass in the angiocath or the suction, the feeding tube. Outlining the minimum competencies that are required for the personnel performing the procedure. So this is going to be done by the the doctor who is working in the NICU. Should it be started by a consultant? What will be the role of nurses, etc.? And to discuss about some important aspects of post-procedure management. A word about nebulized surfactant administration. It has been very attractive to even consider this idea that surfactant could be given with a nebulizer, because the eventual point of delivery of surfactant is the baby's lungs, the alveolar liquid interface. However, evidence on nebulized surfactant delivery, which has been coming in from Dargaville's group, has been coming in relatively slow. There are 3 types of nebulized surfactant, including the jet nebulizers, ultrasound nebulizers, and the vibrating membrane nebulizer. The vibrating membrane nebulizer is by far the best device for substances with high surface activity, such as surfactant. So with the laryngeal mask airway, the other technique that has been tested for giving surfactant, the advantage is it avoids the need for endotracheal intubation, especially if intubation is difficult, and potentially may reduce the need for ventilation also. But challenges include ensuring proper placement of the LMA to maintain a secure airway seal and administering surfactant effectively without causing aspiration or leak. So while using a LMA, ensure that there is proper placement of LMA to maintain a secure seal and administer surfactant effectively without causing aspiration or leak. Now, when it comes to the evidence comparing LMA versus Ensure, there are 5 studies doing this comparison, and there is a reduction overall in the need for mechanical ventilation anytime, that is from hospitalization to discharge. There is a number needed to treat being 7. But this evidence seems to be limited to 4 studies, which included 236 infants, where analgesia or sedation was routinely used in the Ensure group, which could have conferred this relative advantage that we see to LMA technique. Otherwise, it doesn't really make scientific plausibility. It may be considered, however, for mature infants requiring surfactant, especially more than 1500 grams and more than 32 weeks. The last segment would be on the recent advances in non-invasive mechanical ventilation, which is, again, one of the important modes for delivering CPAP. Earlier, CPAP was a bridge between a baby who is being extubated from ventilator and nasal cannula or high-flow nasal cannula. Now we have another interface between CPAP and invasive ventilation in the form of non-invasive ventilation. Usually it is called as nasal intermittent mandatory ventilation. Now, there has been a lot of interest on NIV modes per se, because we know that there is a significant reduction in the surfactant administration as well as in surfactant therapy when we avoid intubation. But there is still need to identify those CPAP failures early so as to rescue them with intubation ventilation and early rescue surfactant. This was the National Clinical Practice Guideline on non-invasive ventilatory support, where the group recommended that even in extreme preterm infants less than 28 weeks, one should not be routinely intubating the baby and giving mechanical ventilation. It should be only used for perinatal asphyxias requiring resuscitation. This may be applicable in settings with high antenatal steroid coverage and adequate expertise in the monitoring of extreme preterm infants. There are 2 types of CPAP devices, constant flow systems, where the flow is set by the physician and pressure is regulated by either an underwater seal, like in bubble CPAP, or with an expiratory valve, like in the ventilator CPAP. There can, on the other hand, be variable flow systems, wherein flow is set by the clinician, and fluidic flip mechanism allows the flow to vary between inspiration and expiration. And constant pressure is generated during both inspiration and expiration. Some people believe this reduces work of breathing, but this has not really translated into clinical benefits. Now, humidified heated high-flow nasal cannula has been also tried or evaluated as primary support in studies of infants with RDS, but was found to be associated with much higher rates of primary treatment failure when compared to CPAP. As you can see, HFNC arm is represented by the blue boxes, whereas CPAP arm is represented by the orange boxes. In all these 3 landmark studies, HIPSA trial, the Indian trial by Dr. Murki's group, and the Hunter trial, in all these trials, the incidence of CPAP failure in the the incidence of primary treatment failure in HFNC arm was significantly higher. So this was the Indian study, which included 2 centers, and they enrolled 272 preterm infants, more than 28 weeks and more than 1000 grams, so relatively low risk for CPAP failure. They randomized these infants to either receive primary HFNC, started at with OptiFlow or Airvo, maximum flow going up to 7 liters per minute, or to a control group which comprised bubble CPAP with PEEP of 5 to 7 centimeters of water. The treatment failure was significantly higher in HFNC group, showing that HFNC is inferior to CPAP as primary mode of respiratory support. Not only is failure rate higher with HFNC, failure occurs much more earlier with HFNC, with the average time of 3 hours when compared to CPAP, where average time was 22 hours for CPAP failure. So when plotted on the plot, the relative risk in this particular trial showed that HFNC was clearly inferior to CPAP. Not only was the point estimate suggesting non-inferiority, both ends of the 95% confidence intervals lied entirely to the left of the non-inferiority line. So then what else can we do when we are anticipating high risk of nasal injury with CPAP, which can range up to 70% in the smallest and the most vulnerable infants? So the interface choice does matter, as has been shown in studies comparing nasal masks and binasal short prongs. All these studies showed that the incidence of CPAP failure was equivalent between masks and prongs. However, the incidence of skin injury was significantly lower in the nasal masks group when compared to nasal prongs group. So this included our DM thesis, which was done at AIIMS as well. The site of the injury in these two category of babies happens to be very different. While with the nasal mask group, the injury is usually at the level of the junction of the septum and with the philtrum or the bridge of the nose. With prongs, the medial aspect of the nasal nares are usually affected. A study from Hyderabad, again published in PLOS 2019, showed that the medium maximum nasal injury score was significantly lesser in the mask group in this factorial design study, which had 4 arms. One group cycled from mask to prong, one group cycled from prongs to mask, and one purely mask and one purely nasal prongs group. So the nasal injury score was significantly lesser in mask continued group, that is exclusively treated with nasal masks, when compared to the prongs continue group as well as rotation groups. So Ram's cannula, which is also coming up, is not traditionally considered as a CPAP interface because it offers high resistance and unacceptable leak percentage. But one RCT, again, comparing Ram's cannula versus Hudson prongs, did show that when used along with the cannulate, Ram's cannula may be able to offer reasonable efficacy as well as safety. The future seems to be lying in the technology of 3D printing for nasal interfaces so that individual interfaces can be developed. Lastly, the role of synchronization using the electrical activity of diaphragm has been advocated by the NAVA technique. So this uses the ERD catheter for measuring the esophageal pressure, which is multiplied by an adjustable gain factor or NAVA level. And this input from the patient or trigger from the patient is used to control the pressure generator of the mechanical ventilator. So this is how it looks in the machine. Last but not the least, we have the technique of closed loop FiO2 control now coming up, wherein the patient's saturations or SpO2 is being fed by a kind of feedback system back to the ventilator so that the ventilator can look at whether the saturation targets of the baby are within range and then titrate the FiO2 accordingly. So it will decrease FiO2 if SpO2 is higher than the target, and it may increase FiO2 if saturations are low. So this strategy has been found to translate into a 15% higher proportion of time spent within the target saturation range. Lastly, nasal HFOV, which works with multiple mechanisms. So this study showing a total of 1,440 neonates with a mean gestational age of 29 weeks. Duration of IMV was longer in the NIPP as well as in the nasal CPAP group compared with nasal HFO. So nasal HFO, although should be used only briefly, it has been shown that neonates who were treated with CPAP needed reintubations more often than those treated with NIPPV as well as nasal HFO. So in summary, these are all the important messages. And if there are any questions, we'll take them up. If there are none, we will close the session for the day. And thank everyone for joining us. And we'll hope to see you again in the next week with another topic that is relevant to all of you. Thank you.